Good morning from the Hawaiian Eye Conference in the Big Island of Hawaii. We're pleased to be here today with Dr. Joel Schuman from New York, New York. Thanks a lot for being with us this morning.
Thanks for having me. I appreciate the opportunity.
Well, I know you have a really great talk coming up in the glaucoma session about a very interesting historical perspective on glaucoma, the artisanal to the defined. Tell us a little bit about what that title means.
So, artisanal is something like what you think of when you think of special bread or cake, or something that takes an expert, and really not just an expert who measures things, but an expert who creates something very special. So, if you think about glaucoma, glaucoma up until really the late 19th century was a totally artisanal specialty. It still is a clinical diagnosis, but at that time, we had no way of measuring what was actually being seen by the clinician. So you would look in the eye from Helmholtz until the time the tonometer was first introduced, and you would see the optic nerve, and you would make a judgment on what it looks like. The intraocular pressure was, what do you think it is? What does it feel like to your fingers? Which we know is notoriously inaccurate even for experts. And then you would also measure the visual field, maybe, with your fingers, and make a decision about whether or not somebody had glaucoma and whether or not the glaucoma was getting worse. And from the mid to late 19th century, we were actually able to treat the disease. At that time, glaucoma was the top of the ophthalmology pyramid in terms of being able to actually treat something. So you could use pilocarpine in order to treat the glaucoma. And it wasn't until the tonometer was introduced that you had any quantitative objective measure of the intraocular pressure. And even with the introduction of the tonometer, people still said, I trust my fingers more than I trust the tonometer measurement. And then, time goes on, you have, mechanical perimetry being introduced, and then the automated perimeter, and then you have optic nerve analyzers, and then finally confocal scanning laser ophthalmoscopy, and then OCT, which give you quantitative objective measures of the optic nerve. So now we have a quantitative objective measure of the optic nerve, we have an accurate quantitative measure of the intraocular pressure, and we're able to measure the visual field, but still it's very subjective, and that one parameter is still I would say the weakest of the triad that we use in evaluating glaucoma. But the point is that now we can make an accurate measurement of whether or not somebody has disease and whether or not that person's disease is getting worse without needing to have an expert actually there evaluating the patient. It still takes an expert in order to assess all of the information, but at a different level. So what I would say is that it sort of flattens the playing field, so that an ophthalmologist in some remote area really can do almost as well as an ophthalmologist at the greatest level of training, at the greatest skill level, because the tools enable us to take care of patients with that level of care.
You bring up some really interesting points, especially about leveling the playing field among ophthalmologists with access to perhaps more technology as compared to others. But I want to go back to a point about the increasing amounts of data that we're accumulating in ophthalmology. And I want to focus on how this affects our trainees. People oftentimes become concerned that if there are more data, the trainees can kind of get lost in the data and perhaps rely too much on supplementary testing and not as much on their clinical skills. Do you think that that's a concern in ophthalmology?
Well, I don't think that the ancillary testing is a bad thing. As I've said, I think it's actually important, and the trainees need to know how to use and evaluate the results of that testing. What I worry about is that the trainees would lose the ability to assess the patient without that technology, because you might not always have it, right? And also, you need to relate those measurements to something that you understand. And it may be that you're working with a different set of tools or a different level of understanding when you're primarily using the ancillary testing. But I would certainly like my ophthalmologist to be able to look in my eye and see the optic nerve and know what's going on with it, as opposed to having no idea what they're seeing.
Well, let's take this to the next step. We've spoken a little bit about where glaucoma has come from and where it is now, but where do we think it's going to be in the next 25 years? Do we see more data, more objective testing coming to the forefront that will affect the way that we diagnose and manage this condition?
Yeah, so there are at least two things that I think are coming down the road within the next 10 years to 20 years. And one of those is the ability to actually count retinal ganglion cells. So we are now able to image individual retinal ganglion cell bodies. It's very difficult. There are a couple of centers that can do this, but it is possible to actually visualize these transparent cells that and to be able to see their shape, their morphology, how they change, and count the numbers, and better understand how the disease progresses, but importantly in terms of patient care, to be able to look at those cell bodies and do a count, as opposed to just measuring the thickness of the tissue. So that's one thing. It'll give us more precision. And then another is the ability to evaluate tissue metabolism. So instead of waiting for the cells to die, that we would be able to measure how well they're working. And to do that objectively and quantitatively, what we can do now, for the first time really, is retinal oximetry, and we are able to measure the oxygen content within the vasculature of the retina in a way that will be scalable within the near future. I think that spectroscopy will allow us to look at things other than oxygen content, but even oxygen content alone should give us information that gives us an earlier assessment of the tissue than we can get just by tissue thickness.
Well, this has been a really terrific summary for us about where glaucoma has been, where it is now, and where we think it's going in the future. What a great discussion this morning. Thank you so much for being with us.
Thanks so much for having me. I really appreciate it.